In part 2 of the introduction to standardized echography, we will discuss some basics of the B-scan displays. The name B-scan comes from brightness modulated display. In B-scans, the echo signals are displayed as bright spots. The brightness of the spots increases or decreases depending on the echo intensity or the gain used. The advantages of B-scan are a two-dimensional display that leads to more attractive imaging. Also, B-scan is easy to understand. Among the disadvantages we find a difficult examination technique, lots of artifacts which confuse, limited diagnosis, and B-scan is unfit for precise and accurate measurements, except for the 50 MHz UBM B-scan, which is even better than the A-scan in those measurements. The B-scan probe emits a sound beam that is focused, and it is in the focal zone that we have the best resolution and that we should use for the examination. In B-scan there is no standardized setting of either the instrument sensitivity or the gain used. When one starts with maximum system sensitivity, it can happen that noise appears in the echogram everywhere, distracting from the real structures. This B-scan system sensitivity setting is way too high. It was 86 decibels in this instrument. When the system sensitivity was reduced to an optimum maximum, the noise had disappeared and the structures are now well visible. It is this optimum maximum system sensitivity that one has to find out for each B-scan instrument and B-scan probe, and with which the examination is always started. It was 10 decibels less than the real maximum, which was way too high. But we always start the examination with the optimum maximum system sensitivity, evaluating the vitreous cavity first. And here is such a case with a dense vitreous and subvitreal hemorrhage, beautifully displayed here with the optimum maximum system sensitivity. But one has to reduce system sensitivity in order to see other areas better, like here the fundus, or the fact that the hemorrhage starts here in the macular area of this eye. It was a hemorrhagic macular degeneration. And when one reduces even further, one gets the chance to see very fine structures in the fundus, like here the fovea. So one always starts with optimum maximum system sensitivity and then reduces to the point where what one wants to look at, what one wants to see, is seen best. Higher frequencies than 10 MHz have an advantage. Here we see the retina overlying a hemangioma of the choroid, and we see the thickness of the retina, which with the 10 megahertz B-scan cannot be seen. And here immersion B-scan, showing the anterior segment of the eye with a subluxated lens. Here the cornea, anterior chamber, pupil, iris, and this is the fluid for the immersion. When one reduces the horizontal expansion, one can see the fundus in these eyes too. With the immersion technique, we get, however, then artifacts creeping into this area which do not help us. So the best way is to use the larger horizontal expansion for the anterior eye segment. And that is automatically done with higher frequencies, like here 25 MHz. The resolution has markedly increased. We see here the cornea, the anterior lens, the pupil, the posterior lens surface well visible, the iris and the anterior chamber angles, and here the ciliary body. 50 MHz has an even better resolution, but also more sound absorption. In this case, we just barely recognize the posterior lens surface, but in most cases, when we use 50 MHz UBM B-scan, the posterior lens surface cannot be seen. In the Quantel Aviso S UBM high frequency B-scan, we have zones of focusing that we can shift. Here the zone of focusing is set for the cornea. Here further posterior for the iris plane, and here even more posterior for the ciliary body. Of course, when we set the focal zone so far posterior, the cornea is not as well displayed as when the focal zone is there. B-scan is used for topography, a topographic evaluation of the location, the form, and the relation of a lesion to the neighboring structures. The topographic B-scan echography is started with the transverse scan. Here we see an intraocular tumor in the 12:30 o'clock meridian. That's the meridian. And in the transverse scan, we lay the transverse scan across this meridian. Since this is a left eye, an odd number, end number, this is the nasal side and this is the temporal side. Nasal about 10:30, temporal about 2:30. And we complement this transverse scan with a longitudinal scan. The probe is turned 90 degrees, and this time the entire echogram is the 12:30 o'clock meridian, from anterior to posterior. And it shows the optic nerve in the back and shows that the tumor is very close to the optic nerve. All this is 12:30 o'clock meridian, anterior to posterior. Another intraocular tumor. Here the transverse scan. It's again a left eye, odd end number. And this is the 3 o'clock meridian where the tumor is located, and the transverse scan goes across this 3 o'clock meridian, here from superior to inferior. The longitudinal scan shows the 3 o'clock from anterior to posterior, here the optic nerve. And the tumor is removed from the optic nerve, it's in the periphery of the fundus. What is this structure here behind the tumor? That's the lateral rectus muscle. Here cross section, typical location, just a little bit below the horizontal, below the 3 o'clock meridian. Here the longitudinal section of the muscles, anterior insertion to the mid-orbit. What is this here? Could that be an extension of this malignant tumor into the orbit? No, it was another extraocular muscle, a typical pattern for the insertion of the inferior oblique muscle. It is very important for the echographer to know the topography of the extraocular muscles well, even when one examines only the posterior eye segment. Here we see the topographic documentation of an eye with a retropalpar foreign body. The foreign body is located here in the longitudinal scan by 9:45 and still visible here a little bit more posteriorly at 10 o'clock, another longitudinal scan. This is a hematoma next to the foreign body, and that is a shadow cast by the foreign body because of total reflection at the edge of the foreign body. And these are inner repetition signals. A retropalpar tumor, very well outlined, encapsulated, roundish, at 3 o'clock in the anterior orbit of a left eye. We see here, besides the shape of the tumor, we see in relation to the globe that anterior tumor surface is flattened out, almost indented. That is a sign that this tumor is not very hard, that the intraocular pressure is enough to flatten that tumor out. That was a cavernous hemangioma of the orbit. If the tumor would have been harder, the globe would have been indented. And here the longitudinal scan showing the neighborhood to the optic nerve, very close. These are shadows cast by the anterior surface of the capsule of the tumor, reached by an oblique sound beam, again a consequence of refraction of the beam and total reflection. We'll talk about this in detail later. The difference between the 10 MHz and the 20 MHz frequency, again here in the case of a hemangioma of the choroid, we see a better resolution with the 20 megahertz. But also more artifacts around the optic nerve, and we are missing here the bony orbital wall that we can see here with 10 megahertz because of the stronger absorption. And finally, measurements of iris cysts, here with the UBM Aviso unit with the B-scan, can be measured in all different directions, here sagittal and more frontal. And when we increased the system sensitivity again, yes, we have now a lot of noise, and normally we wouldn't do that, but what we can't see in this scan is there is a smaller cyst next to the big cyst here, and that could be measured at this setting of the gain.